Okay. So yeah, this is a 26-year-old graduate student with schizoaffective disorder. He was brought in and was admitted for a recent onset of behavioral change, including not speaking and pretty much in the same position, immobile and posturing. He had stopped taking his Risperdal about the previous 2 weeks. On exam, he is staring and he's posturing. He is not speaking. No fever. When you examine him, some mild rigidity. His Bush-Francis Catatonia rating scale has a score of 13, and his lab tests are unremarkable. So what do we do? So we will turn to our expert later, but maybe others can chip in. And what's the first step, treatment-wise, that we would want to do with someone like this? Anyone speak up, or maybe I can volunteer. Maybe Pega, you can say something. You're a recently trained psychiatrist.
Yeah, I think because the symptoms are started without taking any medication. For the treatment approach, you mean?
Can you say it again?
I can. So are you asking about the treatment approach for this patient?
Yes. So what would be your next steps?
I think I'm starting the benzos for this patient and keep disconnecting risperidone since until the symptoms recovered, and then I'm going to start the medication again. So for now, I think if it was my patient, I just started with the benzos.
I see. So your choice would be to go to a benzo as the first choice and hold off on the risperidone for now.
Yeah, because I think that the catatonia manifestations and the etiologies is different from in affective psychosis versus schizophrenia. So I think we should have different approaches if the patient has the symptoms according to schizophrenia versus schizoaffective or bipolar disorder.
Yeah, let's see what other people think.
Yeah.
Johan or Lynn?
Yeah, happy to say the first thing I do is admit him to the hospital. I assume you brought him to the emergency room, but I do this as an inpatient admission because you don't know if he's eating, if his electrolyte balance is okay, etc. But risperidone is not the antipsychotic I would use with someone who has catatonic episodes. I'd probably have him on olanzapine. It depends. If you get him on the ward, I think it's right that I wouldn't start an antipsychotic right away. Main thing is the benzos. So
a critical question would be, would you start him on a dopamine blocker and a benzodiazepine together at the beginning, or would you do them sequentially?
Yeah, I would do it sequentially. I'd be interested to see what Chris does, but I certainly would not put him back on risperidone because of its.
So I guess what you have as a worry in the back of your mind, Lynn, is whether there is a possibility that this might be an atypical Parkinsonian response to a dopamine blocking antipsychotic, and whether that would enter into the differential diagnosis, right?
Yeah, It's possible.
Okay. So that is a very, very reasonable approach. Chris, what do you think?
Those are excellent points. I think it's a complex presentation. On the one hand, it seems that there is a direct connection between him having stopped taking his antipsychotic and this presentation, but risperidone also has a longish half-life, and the clinical picture could be suggestive even of neuroleptic malignant syndrome. So I would like first, I feel encouraged by the fact that the labs and imaging are unremarkable. On the other hand, there is no lab specific for NMS. So I would also want to know whether there is neurovegetative instability, how are his vital signs, if they are stable, and if his CPK is increased or his white count is increased. So I think that's a good point. We don't know much about this student. And although catatonic schizophrenia used to be probably the main presentation of the illness a while ago, things have changed and we can't be sure. And obviously we would get a little more history and from somebody who knows him and see if this has happened before or it's a new onset type of episode. We've been talking about giving him lorazepam or a benzodiazepine. I think that might be a very good starting point because since there's a postulated link between NMS and catatonia, even if this is to be NMS, adding a benzo would be helpful and avoid further complications. I wouldn't take very long, in my view, until I would restart him on antipsychotic, because I think there is a direct connection between this young man not taking his antipsychotic and coming down with this presentation. And in that case, that will indicate that being on the antipsychotic prevents this from happening. So once I am sure that this does not look like NMS, I have a diagnosis of schizophrenia, I have a previous trial of risperidone, and if that was effective, I would consider resuming risperidone.
Okay.
There are a few schools of thinking, and I know that as Lynn is mentioning, risperidone might not be the best choice in his case, because if this is a hypodopaminergic state, with adding a dopamine blocker such as risperidone, we might not be able to get the best results. So there's always the possibility of using a partial agonist agent like aripiprazole or something that may be even an antipsychotic with a low dopamine activity, such as quetiapine or clozapine. But those are always based on the history we get. If the risperidone seems to be the antipsychotic of choice and the patient has responded to it, I think that would be a consideration as well.
Yeah, it looks like both you and Dr. Delisi seem to have a bit of a consensus, and that you would prefer to start a benzodiazepine as the first choice, and you would certainly bring back in the dopamine blocker, but at a later time point. And the second point of consensus is that risperidone may not be the greatest option here, and something that is a little bit less D2 specific might be the way to go, right? So any other thoughts from others? Okay, let's see what happened here. Lorazepam was given 2 milligrams IV initially as a challenge, and Mr. R began to move and speak. And it was then continued orally, Q6 hours, 2 milligrams, and in 5 days, he fully resolved. And exactly as we discussed, the antipsychotics were withheld until he recovered from the catatonia, and then he was started on aripiprazole. So you both kind of read my mind in a way. So it's an interesting case to learn about the management approach, and also to think about what might be the pathophysiological underpinnings of catatonia. So I kind of raise these questions for the group to consider. One is, how did lorazepam do its magic? What might have been the key therapeutic ingredient here? And the second question is, why delay dopamine blockers? Why not start them together? And what would we do if lorazepam had not worked in this patient? So let's see what people think. Any of you?
Yes, these are very good questions, but they're also very difficult to answer.
Yeah.
I mean, these are at the heart of the whole thing, really. I mean, do we really know what causes catatonia? I mean, because benzos work, they aren't obviously working on the dopamine system, and yet I don't know. The dopamine system may actually be initiating catatonia. I'm not
So
sure.
the question is, the lorazepam is a GABA agonist.
Right, right.
So would there be a GABA mechanism in catatonia?
Right.
So Pega, you have done some research on this. You tried to write a paper on this. So what do you think from the literature?
Yeah, I think some of these manifestations for motor signs for catatonia can be explained by indirect pathway. And indirect pathway, dopamine is also important, but the GABA is also important because increasing in GABAergic signaling will causes increasing thalamic inhibition, which decrease the movement. So if we uses the GABA, we could just reverse this system and causes we can just resolve this inhibition in movement. And also dopamine is involved in this system because decrease in dopamine will increase in indirect pathway, which causes decrease in movement and hypokinesia. So it means that increase in GABA and decrease in dopamine is involved in the catatonia. So if we uses the dopamine blockers, it will decrease again the dopamine, and it will causes the catatonia symptoms worse. But if we increase the GABA with the benzos, we can just facilitate this movement by increasing in GABA and decreasing the movement. Increasing the movement.
Okay. So basically you're saying is that there are, two neurotransmitters that are involved here. Perhaps, GABA being too low and dopamine being, blocked, or the antipsychotic effect.
And there are also other neurotransmitters that is involved. So all the medication that we use for the catatonia are based on the neurotransmitters that are involved in indirect pathway. So the other neurotransmitters are involved, the dopamine, GABA, glutamate also, and maybe serotonin also is involved. And so we can just adjust these neurotransmitter by the medication so that we can change the movement, or I mean the inhibition of movement.
So, I mean, you anticipated my slide. So I put together this slide where there are 3 neurotransmitters that are involved. There is dopamine, which acts in 2 different ways. One is through the direct pathway, which is through D1, and it acts through indirect pathway, which is through D2. And what catatonia might involve is perhaps an excessive inhibition of the D2 through the indirect pathway, leading to a shutdown of the motor pathways, leading to inhibition of movement. That's what you're saying, right? So one way to address that would be to either stimulate dopamine through a dopamine agonist like amantadine, or through a partial dopamine agonist like aripiprazole, or use a benzodiazepine agonist such as lorazepam, or zolpidem, which we'll turn to Dr. Kokancha to tell us about, or maybe to inhibit the excessive glutamate by something like memantine. So let's go back to the case.
And also, sorry to interrupt, I also found that the GABA-A is decreased. So this is the problem for GABA-A, not B.
GABA-A, right.
Yeah.
And so benzodiazepines are, they're generally non-specific, right? They work on many GABA receptors, but they specifically, they do enhance GABA-A. Is that right?
Yes. But for example, baclofen works on GABA-B, and we cannot use it in the catatonia because of this.
So that raises the question, what if lorazepam had not worked here? Chris, how would you approach that if in a patient like this, the lorazepam even up to 20 milligrams was not working?
Yes, you are completely right. One of the reasons of benzodiazepines not working is dosing, and catatonia is a condition where notoriously higher doses are needed, as you said, up to 20 milligrams. So obviously, the first approach would be maybe to try to increase the dose, or maybe to increase the frequency, because the patients tend to relapse after a few hours from the administration of a dose of a benzodiazepine. And in cases when they do not work, or there is any contraindication on going high to higher doses of benzodiazepines, I've been trying to use zolpidem. And there is an interesting relationship between zolpidem and benzodiazepines, which maybe sheds some light into the mechanism of some forms of catatonia. As it happens, zolpidem is the most specific ligand for 2 subunits of the GABA-A receptor, alpha 2 and 5. Benzos are not that specific. Benzos are ligands for all the subunits, and that may be the basis for improved response with zolpidem. I have colleagues who have, and I work with them in developing guidelines where a test for catatonia could be the administration of 10 milligrams of zolpidem, DO, and monitoring the patient for response to the point that it's so highly specific that it almost rules out catatonia. But we know, as Pega mentioned, that there are many other forms there are other mediators involved which explains, if you look at interventions for catatonia, going down the list, almost there are 15 or so agents that have been tried, including NMDA agents. I personally treated a number of patients not responding to benzo or zolpidem with memantine, and they showed a very brisk response to catatonia.
What's the dose of memantine you would give?
In the patients I treated, I used 10 milligrams twice a day.
Okay. And
But again,
yeah,
it's pretty much clinical. It all depends on if you see improvement, then when the effect starts losing, then you administer the next dose.
right. So memantine works, but it's an NMDA antagonist, right?
Yes.
So basically, if there is an excitatory inhibitory imbalance with too much glutamate and too little GABA, you could correct it by either increasing the GABA function or decreasing the glutamatergic function. So the decreasing glutamatergic function by an NMDA antagonist like memantine would be the way to go then.
We know that there is a deficiency of GABA-A type of receptors in the prefrontal cortex of those patients, because there's been imaging work done by a French group looking at the density of the GABA-A receptor in patients with catatonia. So in most of them, they have been able to demonstrate a lack or a decreased number of GABA-A receptors. And probably that is the basis for most patients responding to benzodiazepines. For the ones who are not, then going a step above and looking at zolpidem, whether it improves their response. And in cases where we see no response, because unfortunately there is cases like that too, then looking at NMDA agents or other approaches.
Let me ask you this question. So is there any reason why zolpidem is not the first choice as opposed to lorazepam?
Well, it is when we first used it was on a patient who was on the unit because wasn't able to was unconscious, unable to eat, take care of himself. So our colleagues in medicine thought that we were nuts because we wanted to use a sleep medicine on a patient who is unconscious to begin with, and the response. So here is the problem. Zolpidem, I prefer zolpidem. It's effective in most of the cases, but it doesn't come as anything else other than PO.
Got it.
So if you need parenteral, if we need IM or IV, unfortunately, is not available. I know that lately they came up with mist. With an aerosol formulation, which is called Zolpi Mist. But with that, you can never achieve the blood concentration that you need, and you get with a 10 milligram PO dose. So there's not much.
So what you're saying is, lorazepam has the advantage of an emergency response because it's available as IV or IM.
IM, indeed.
Yeah. So yeah, that makes a lot of sense.
And catatonic patients are notoriously not very interested in taking things by mouth to begin with.
Yeah, yeah, yeah.
Right.
That's very true. Yeah, yeah.
Can I ask you, Chris, so one of these things works in the patient. You get the patient stabilized, they're not catatonic anymore. How long do they have to stay on these medications? And I get varying responses from people. On the acute units, so I work in the outpatient department, and I'll get a patient who's on, 15 milligrams of Ativan. What do I do?
Well, those are great questions, and I'll in my experience, I had patients responding to zolpidem up to 40 milligrams a day. I tried to switch them to benzos and then taper down. Some of them lost the response. So there was a number of patients who needed to take zolpidem long term, and that's where things are not so well studied, because zolpidem is a sleep medication which is used at a maximum of 10 milligrams for most people, and intermittently even, so we've seen the tolerability seems to be there. We haven't seen a withdrawal and I discharge patients with up to 30 milligrams of zolpidem per day.
Right.
And that was for long term. They stayed in the hospital for a few weeks and they left. And for a good reason, because every attempt to get beyond that dose was met with a return of catatonia.
I have a patient who both you and Lynn and Chris have seen in different settings. This young man is on clozapine. He has what looked like catatonia a little bit. His score on Bush Francis will probably not be more than 3 or 4. Very mild grade catatonia, and he was treated on the inpatient with a large dose of you treated him, Chris, with a large dose of zolpidem, and then I titrated it down. He's now on only 10 milligrams, but he still has a bit of this posturing. When he goes to the bathroom, when he tries to brush his teeth, he is kind of frozen there, whether to brush his teeth or not to brush his teeth, whether to put his toothbrush down or bring it up. So, but he's fully aware of this. And so you can call it catatonia, or you could call it a obsessive ambivalence. And when I dropped the dose of zolpidem from 20 to 10, this behavior got a little bit worse. So would you go back and maintain him on 20 or 30 or 40 of zolpidem?
Okay, that is one of the sickest patients I've seen. Because of a few reasons. He's young, and one would not expect such a degree of treatment refractoriness to almost everything. The other is, as you mentioned, the differential includes obsessive type of manifestations, which after all could be also catatonic behaviors. I'm sure everybody here remembers, for instance, in Krepelin's textbook, there is a photograph of a bald patient. And he wasn't born bald. He pulled his hairs along the ears and ended up without any hair. And that's being considered a catatonic type of behavior. With this young kid, we tried also memantine, I think.
You tried him on memantine.
You did. We did, and it didn't make much of a difference, unfortunately.
That's what I recall,
we did ECT, and he may still be doing maintenance ECT.
He's still on maintenance ECT.
And, but unfortunately, with everything, the improvement has been minimal at best.
Right. Yeah. He's on clozapine, as you know, and so he's on everything, under the sun. So where does one go with something like that? So, but catatonia is not the main part of his problem. So it is the extreme negative symptoms and continuing hallucinations. So we are really at a treatment-resistant psychosis situation. But what if the catatonia itself is the main problem and it's not responding to either lorazepam or zolpidem? What would be your next go-to option?
Sorry, can I ask a question?
Yeah.
If we wanted to start it with, zolpidem instead of lorazepam, the delirium may happen because zolpidem high doses. So how can, and this delirium will participate the catatonia symptoms itself. So what can we do with delirium?
Pega, this is a great question. It makes one wonder. Catatonic patients can tolerate huge doses of benzos and of zolpidem, and that's the pathophysiology of the illness. I have not seen patients getting delirious with the benzos. That would be a strong indicator that something else other than catatonia might be happening, including delirium. But by nature of this condition, they can tolerate fairly high doses of benzos and zolpidem.
Well, as you alluded to, Chris, there is a value in using zolpidem as a therapeutic test, right? Is
Yes,
that what you're proposing?
I've proposed that diagnostic test, but with the 10 milligrams of zolpidem. If the patient can accept, most of the patients will show response within 15 to 30 minutes. It's quite dramatic to see the improvement.
And the same thing you would expect with a 2 milligram dose of lorazepam as well, right?
I've not seen that extent of response. It's really very fast with the zolpidem. It happens obviously with lorazepam, but not to this degree. And
I wonder if anyone has tested whether the single dose of zolpidem would enhance the GABA levels in the brain. It's measurable using magnetic resonance spectroscopy. You can actually measure GABA levels. This could be a biomarker-based test, right? In catatonia.
Yes.
Something that could be a research project in and of itself, worth considering.
We see a lot of patients on the CL service where, and this could be like, there's some diagnostic lack of clarity, but, I've seen people with catatonia who do seem to present afterwards with delirium, but they may have like other medical comorbidities contributing. And it does feel like a little bit like a Gordian knot. And then you start to kind of like, it's like this subtle change where you're like, no, I actually think it's more confusion and less catatonia. And then you start to, like, it's like almost like directly, the catatonia resolves into a delirium, if that makes sense. And then you kind of start tapering it and then they get better. But it is a really tricky, and then some of the features overlap. So that's something we often struggle with on the consult service.
I did want to ask, I know Elizabeth, Ashley had mentioned you guys have had a number of cases related to this recently. Is there anything kind of specific that's come up around this that has been particularly challenging?
So my background is neuropsychology, so I have a little more like background than a standard therapist would in brain behavior relationships and doing movement disorders and whatnot. So the on off of the dopamine receptors, I'm familiar with all that. But catatonia was simply not something that was covered at all in any of our trainings. And as it happens, I have like 5 people on my caseload now who have a history of catatonia. One I just called crisis on Thursday, and they're back at the hospital again. They had been in the hospital since July, and there was a comorbid history of autism there. And we have a new referral who's been coming to the milieu, who is an identical twin, and the identical twin has too many developmental delays to be a candidate here for our program, but they have a large history of catatonia, and they've been hospitalized several times for that. And this twin that we see now had been starting to experience urinary incontinence while in the program, and some grimacing, posturing, and not really responding. And we were just like, is this catatonia or not, or is this psychosis? And we have a med provider here that's here on Tuesdays, and we've done a lot of back and forth with him. And his take was that it's more psychosis, but it's very hard for me to tell, just because doing these this BFCRS, I went and looked online and I watched the YouTube clips on those just to see what it is they're looking for, like what these terms mean. So it's not something I've had any training in. So it is like a sizable amount of my caseload now. So I'm just trying to get as much information as I can. And this talk is very helpful, actually. That seems strange that benzodiazepine and zolpidem would bring someone back online, even at high doses. But yeah, it's a conundrum to me.
Thanks for bringing that up, Dr. Burns. You raised the question of Bush Francis, how to do that and so on. So that's why I put this slide on. And it also can cue us into a DSM-5 diagnosis of catatonia. If we are able to do that rating scale, if in the same period of time, if there are more than 3 items, that would be DSM catatonia.
Okay.
Now, you also bring up an interesting point from your case. It looks like this person might have some kind of a developmental disorder and no clear psychosis, right, outside of this catatonia. So that
go ahead.
That highlights the point that catatonia may be so transdiagnostic that you may see that across a variety of disorders, including neurodevelopmental disorders, maybe autism spectrum disorders as well. And I've seen patients with what you might call intellectual disability also having catatonic syndromes. So it's important to be sensitive to this transdiagnostic nature of this condition, whatever we call it. Which clinic do you practice?
This is the PrEP clinic in Holyoke, Massachusetts.
Oh, the PrEP West. Okay, yeah.
Right.
All right, great.
And we are one of the few that has a milieu where people come in for day program. Okay, yeah.
We might be coming there sometime in the near future, right?
Yeah, I think at the end of the month we'll be there.
Yeah, we will be. Yeah.
We got to get our data sets up and ready in preparation. But I would, to your point, 5 out of the 6 people that have on my caseload have a history of developmental limitation, either autism and or intellectual disability. And there's something to that for sure. It's just
that's a very interesting association between neurodevelopmental disorders and catatonia, which may not have been covered much in the literature. So you might want to think about publishing something like that as a case series.
Sure.
Chris, have you seen any literature on neurodevelopmental disorders and catatonia?
No, I have not. I was thinking that on a related note, showing how complex this condition is and how it cuts across diagnostic categories and even pathology. The first case of zolpidem described in the literature comes from a CL group in France, and they gave zolpidem to a patient who was post-stroke. She was she looked paralyzed, and her eyes were opened all the time. She wasn't even blinking, and they thought that by giving her zolpidem, she's gonna sleep and maybe close her eyes and avoid corneal lesions due to dryness because of that. And they gave her 10 milligrams of zolpidem and were shocked to see that within 15 minutes, she actually got up from her chair and started preparing a meal for her husband. So, and that was not as a patient with psychosis. She'd never been psychotic in her life. It was and the other idea is people from the groups of doctors Francis and Bush talk about they've seen such a response to zolpidem that they talk about zolpidem rounds. They go to state hospitals where they treat people with vegetative conditions or chronic conditions, and they try to identify those who are actually catatonic and give them test doses of zolpidem to see if they can actually get them out of those units.
Yep.
Can
Yeah, go ahead.
I was kind of wondering, but how is it handled on the outpatient side of things with benzodiazepines and like the Z class with the zolpidem with regard to tolerance and dependence? How that's managed if that's something that happens over time with them, to prevent too much tolerance from happening so that they are responsive to it.
That's a great question, Chris.
I think for as Lynn was mentioning at the beginning, for the most part, catatonia is a hospitalizable condition, is a criterion for hospitalization, because if allowed to progress, then patients become kind of unable to take care of themselves. The opposite is true either. You will see patients on benzodiazepines at the tail end of their treatment. They've been in the hospital, they've been discharged on benzos, and sometimes the tendency is to take them off benzos to maybe too fast, and then to see that things kind of relapse. So they will be coming to the outpatient, to an outpatient office on various doses of zolpidem or benzos or other anti-catatonic agents, and they are able to function with that. But as a new onset, or if it's worsening, I think it's always a criteria for admission.
Yep, it's very helpful. Thank you. So what does one do? Come back to the question. Would you go to ECT if both lorazepam and zolpidem are not working? Is that the next step, or would you try tinkering with amantadine or memantine and so on?
ECT is still considered the treatment of choice for catatonia. And you mentioned zolpidem and benzos. Zolpidem has the advantage that can be administered before ECT without raising the seizure threshold, which benzos tend to do. So from the standpoint of the patient being treated with ECT, I think the zolpidem is better. We've used combinations of benzos and zolpidem, especially for the day before or the day of the ECT treatment. Some patients who require administration of benzos or zolpidem 3 or 4 or 5 times a day tend to relapse before they go to ECT. So being on the unit, they get a dose of zolpidem, and then they can go and have ECT treatment and come back to the unit. So it's an interesting
So I put
protocol.
here the algorithm that was published by Joel and Wilson. In fact, who will be speaking to the MapNet group in the next few weeks sometime? Kelsey, you may have a date.
I think in November, actually.
November,
but
yeah.
yes, yeah, in the next few
So
months.
she spearheaded this national consensus on an algorithm for treatment of catatonia. And exactly as we discussed, after we have tried lorazepam and maybe other non-benzodiazepine GABA agonist, and if they have not worked, ECT is the way to go. And of course, then there is a glutamate antagonist like memantine, and a dopamine agonist like amantadine, and an anti-epileptic like valproate, which could be considered as later options. So we sent this PDF article by Wilson, which is a consensus on practice guidelines for catatonia, to all of you. So hopefully that will give you some ideas as to where the field is going. And
I would suggest adding the zolpidem up as an early intervention, as the challenge dose.
Yeah. Well, that is a really cool idea, Chris. Somebody has to develop that as a test and publish that. That might actually be quite helpful.
Yes.
Yep. All right. We are coming down to the last 5 minutes. Any other questions or thoughts that people want to bring up?
Yeah, Kish, I'd just like to, since I sort of like to conclude this with the fact that, way back 50 or so years ago, catatonia was much more frequent, and you could find it on the back wards of psychiatric hospitals. Amazingly, walking down the hallways and seeing people with their arms up and immobile and mute, etc. And then it seemed to have disappeared for many years. And I noticed when I was working on the inpatient unit at Cambridge Health Alliance that after COVID began, we got an enormous number of new admissions, slightly older than the usual first episode psychotic patient, but with catatonic symptoms, a lot of catatonia. And I just wonder if there's an infectious origin,
That's such a great point. I used to see a lot of catatonia. I mean, you and I go long back in this field. So
Right.
I remember the days when catatonia was quite ubiquitous.
Right.
And I trained in psychiatry first in India, where we used to see a lot of those. And my first case that even stimulated me to go into psychiatry was a young man who was brought in from a nearby village. He was brought in on a bullock cart like a statue. He was standing like a statue. So he came in, he was stiff as hell, and was seen by neurologists who did a lumbar puncture. Nothing was found. And then psychiatrist was called, and psychiatrist took one look and said ECT.
Yeah.
This was in the late 1970s. I was a medical student. And so he completely cleared up within a day or two, and he explained why he was standing like a statue with his hand upheld like this. And I asked him, why did you hold your hand like this? He said, the village was going to be flooded by the river, and I could stop it. God told me to stop it with my hand.
Very interesting.
And so they often have these kinds of explanations that will come out when they are they bring them out. They can give us those explanations.
Yeah, they have a reason. It's very
There was a
true.
reason, yeah. So, and he was also running a little bit of a fever, and he had not been eating properly for a few days. So, nutritional factors and infective factors might trigger catatonia, as you alluded to. So that's a possibility. We need to understand that better.
I wish we could discuss this longer, but I have to go to my next meeting. But really good conversation.
Yeah, thank you. Thank you all. Thank you for the discussion. And thanks, Chris, for making it so insightful clinically.
Yeah.
Okay.
Thank you for inviting me. Thanks.
Yeah, of course. Yeah. Thanks. Bye-bye.
Bye.